So what I'm going to be talking about is decision making, or more what we call executive functions beyond decision making. So, and that's we presume is mediated by the frontal lobes of the brain. So before I jump into that, and some of you may recognize me, I was at the Iowa City VA, and I've since transferred to Virginia Commonwealth University's Department of Physical Medicine and Rehab to continue my work with brain injury and rehabilitation. All right, so just disclosures. So I don't have any financial relationships with proprieties or entities that produce healthcare goods or services. And the opinions I'm going to be talking today are mine and don't represent Brain Injury Alliance of Iowa, Virginia Commonwealth University, or any other entity. So kind of what I'm hoping is to do an overview of what executive functioning is, what problems may look like, do a couple case presentations, and then leave time for discussion. This is a really interesting area for me because frontal lobe injury or executive dysfunction can be some of the more challenging issues to address and to treat, and can cause behaviors that really are problematic and can really have a marked impact on somebody's functioning in multiple domains. So just a brief overview, refresher of the brain. The first slide shows the frontal lobes in yellow. Parietal lobes, those are more dealing with organization, processing. The temporal lobes, more emotion. And these are gross statements. And then the occipital lobe, processing of visual information. Cerebellum, balance and coordination. But we know that all of these areas are linked together. So when I'm talking about people that have suffered brain injuries, whether acquired or traumatic, people may have executive dysfunction or problems with frontal functions, but oftentimes that's also in combination with other deficits associated with any brain injury. So in addition, there's also on the bottom part of the brain, let me see if I could draw this. Under here, there's more what's called white matter. And what that is are axons that have fatty myelin sheaths around them that help the signals go quicker. So the frontal lobes are connected as well to other areas of the brain. There's going to be three areas. I'm not going to get too much into the neuroanatomy of the frontal lobes, and I wanted to come up with a slide that showed the dorsal ventral part of, and then these three areas: orbital frontal. Sorry, I'm not sure if you can see orbital frontal. This is a terrible drawing. If I can get rid of that, I'm just knocking it out. And the dorsolateral. Now, this is in French. I couldn't find an English slide. So, but I am going to be talking about damage to that specific area. And right by the motor cortex, like right about here, is something called the motor strip. So if you've seen the homunculus, which is a diagram which shows like there's be an arm right here, a tongue, a foot. It's where the brain is perceiving movement and generating movement from that strip. And then there's an area right here called Broca's area, which is involved in language as well. So those areas can be implicated, but I'm not going to get too specific into those because those are more what we call anterior frontal lobe. Really what I want to talk about is executive functions. And this shows this as well. So the motor, you'll see here the motor cortex. These are the frontal lobe is here, and then Broca's area is right here. So that's enough of the neuroanatomy for today. So executive functions, they're presumed to be controlled by the frontal lobes of the brain, although other areas are implicated in their work. So this is what's involved in higher order thinking, if you will. So there's a number of key executive functions, and ones that I particularly pay attention to as a neuropsychologist when I'm doing assessments, and then also as a rehabilitation psychologist in doing intervention. So trying to work to work around some of the deficits. So some key executive functions, and these aren't, you'll notice I'll add additional ones, but these are I just wanted to get started with this. So task initiation, that part of you that is the get up and go. So getting started on something and then following it through to completion. Also working memory, and I'll talk about each of these in a little bit more detail. Organization, planning, and then really importantly, adapting when a plan goes awry or needs changed. And then also prioritizing what to do first and what to do second and what kind of sequential order to go in. In addition, frontal lobe or executive functions are involved in self-monitoring or keeping track of what you're doing. And this includes insight. So your understanding of what's going on and your understanding of how your brain is working. It also involves something called metacognition, which is really the ability to be able to think about thinking. So this involves insight, it involves self-questioning, self-regulation. So just a number of different things that do align across the board with insight and self-monitoring. Impulse control, so the ability to stop yourself from acting on an impulse or a thought. And then also frontal lobes are involved in mood and personality. All right. So I'm going to go break these down and go through them. So task initiation or getting started and task completion. So this is an area that's controlled by the frontal lobes of the brain. And we know a lot of this initially because of lesion studies. So somebody would have a stroke in a certain part of their frontal lobe or a certain part of their brain. We would see what the deficits were and then be able to extrapolate that area controlled that. Well, our understanding of the brain is more involved now in different areas, or, different connections are there that we didn't previously know about. So this is somewhat simplistic. But with task initiation, it really is that it's the initiation. It's not the motivation necessarily. Some people have motivation to do things, but just can't get that task started. And in addition to that, not just getting it started, but following it through to completion. So not just getting distracted, but just kind of losing motivation, losing, impetus to go forward. So people often will start things and then not finish them. This may involve apathy, and I'll talk a little bit more about that, which is basically kind of the loss of caring about things, not having the same interest level as before. So that certainly can be a factor. Going on to working memory. So basically working memory is the bridge, somewhat of a bridge between attention and short-term memory. So it's a component of attention where you take in information, you're able to, basically mentally manipulate that information to generate a response. So one of the best descriptions of this is on testing, to assess this, I'll often do mental arithmetic, and I'm really not concerned about the person's math skills. It's the ability to hear a problem, then hear the details to be able to work out that problem mentally, and then generate an answer. So this does involve more complex attention and mental flexibility, if you will, and that ability to hold things online and not kind of lose them very quickly. So problems with working memory often result in a lot of different difficulties, and they look like attention problems, but they're actually a little bit more complex attention problems, and can get in the way of somebody's ability to work. It can get in the way of relationships. It can get in the way of a lot of different things, because once things start to go wrong, there's problems, and it just breaks down. There's a lot of breakdowns in, say, communication and other things along the way. All right, so organization, planning, and adapting a plan when needed, and prioritizing. So organization involves a broad range of activities. So you want to come up with a plan, and also critically, when you face, as we all know, that we come up with a plan, sometimes things don't go as we expect. So the ability to think on one's feet and change that plan to meet the needs of the situation are part of what's controlled under the frontal, or controlled by the frontal lobes. So when we see executive dysfunction, often see organizational skills that are really problematic. This can impact daily functioning, such as taking medications, financial management, tracking appointments, just engaging in activities, and then often misplacing objects. Sorry. So somebody's doing something, they place something down, they walk away, and they don't remember it. So it's less of a memory problem because it's not being stored into that deep term memory. It's more of an attention issue because attention tends to be more short. So this is that middle ground. Let's see, also problems prioritizing what is important and why. This is critical. So if you're starting a task and you don't know how to prioritize it, that task probably isn't going to get successfully completed. So being able to prioritize is critical. And also to be able to adjust that prioritization. So again, I want people to think about mental flexibility. That is absolutely critical as far as executive functions. So with executive dysfunction, we often see people that have issues with time management or time perception. They have to be cued for things, or else they'll miss them, and just not a good perception of the passage of time. Impulse control. So this is one of the more challenging aspects of frontal lobe injuries. So impulse control is the ability to basically stop oneself from acting on an impulse. We have a lot of thoughts that come in our head. A lot of them we shouldn't act on. Like somebody pulls in front of us, might want to say something, might want to do something. Better to inhibit that and not go down that emotional roller coaster. Also, the ability to not spend on a whim or really engage in risky behaviors without thinking about the consequences of what might happen. So again, it's thinking, it's not really taking that time to think, it's just acting. So impulsive behaviors are, with executive dysfunction, we see a lot of impulsivity, and this can include excessive risk taking. So doing things that are unsafe, driving quickly, doing drugs, drinking and driving, risky sexual behaviors, just a whole cornucopia of different things. And this is often seen with people when people are sort of acting again without thinking. So they'll get irritated and then just respond. So there's a 0 to 60 response for frustration, and basically don't have time to say, hey, wait a minute, let me take a step back. Maybe this isn't what I think it is, and to kind of process that information. Rather, it's being in the moment, something happening, and then immediately responding. And oftentimes afterwards, if there's impulse control problems, people will have insight into the fact that this, that this was a problem, and that, I wish I could have had a couple seconds to process this a little bit more deeply, or to think about what I was getting myself into, such as me agreeing to give this talk. No, just kidding. All right. Oh, whoops. Sorry. Okay, wait, here we go. All right. So the next one is self-monitor. So it's really important for us to have insight or awareness of what we're doing, how we're interacting with others, and how we're behaving. So self-monitoring is a complex process. It also involves the ability to make changes to now allow the person to be able to meet the demands of their environment, knowing what skill sets they have, knowing what abilities they have. This is also involved in self-motivation to a degree as well, so that, if we think about the task initiation, this is the precursor to that. So those that have had frontal lobe injuries, tend to lack the ability to see the consequences of their behaviors, not only on themselves, but for others, and what the potential long-term consequences are of, acting in a manner that is causing issues. So interpersonal problems are very common with this, because the person is not really monitoring how they're interacting with others in an appropriate manner. With frontal lobe injuries, we often see people sometimes are described as self-centered, but it's more they're just having to focus. I think they're having to focus so much on themselves because they have problems in this area that other people, picking up on the subtle cues and things like that are missed. Now, that can also be due to other neurologic damage, but certainly that is a factor that I see a lot. It also affects, how somebody's going to deal with problems and taking care of oneself. Yeah. So, and then again, these are going to overlap. So this also is the inability to learn from the consequences of behavior, and that's critical for all of us. All right. So the next thing that can occur in traumatic or acquired brain injury are changes in personality. So personality is a broad term, and there is we don't have any real sense of where we lie in our brain, or where personality is, or if you want to say the soul. There's different permutations of that. However, we found from injury studies that clearly the frontal lobes play a critical role in personality. And if somebody has a frontal lobe injury, it can really result in marked problems or marked changes in personality. Sometimes it's bad, sometimes not so bad. So kind of with executive dysfunction, deficits in the give and take in conversation. So a term we call social emotional reciprocity. That's when you're having a conversation and you're both on the same level. You're both, empathizing or understanding what each other are saying. That it's an equal conversation rather than being talked to or just talking to somebody. And it may also manifest in total focus on the self, really, and not tending. And this happens more with the severe injuries of not really having a sense of what other people are feeling or thinking, or the ability to perceive that. That's critical because in social interactions, it's not just a one-way street. So when that system breaks down, it can cause a lot of different, problems as far as just relationships. Also, we see reduced or lack of concern for others at times. So people may become less empathetic. In addition, people may sort of blurt out things. This goes along with impulse control, but a tendency sometimes for people to be more blunt and be more direct, way too direct, and not doing this to hurt somebody or hurt somebody's feelings. In fact, not really appreciating the fact that bluntness isn't necessarily something that people want to hear, particularly if you don't know them well or depending on what you're saying. We also see social inappropriate behavior may arise after frontal lobe injury or executive dysfunction, and this can run the gamut. So it can involve sexually acting out, being inappropriate and with making sexual advances. It can certainly lead to excessive spending, gambling issues, and just problems with social interactions overall. If you think about it, the friends that you have in family and what you enjoy about being around them, it's usually the communication and knowing that that person cares about you, understands you, and vice versa. With frontal lobe injury, those skill sets can get lost again. And again, the person can look like they're very self-centered or narcissistic, but that's not really the case. This is not something that's based on a psychological process. This is based on a neurologic process, so damage to those frontal lobes of the brain. Personality changes can also include, and again, this is repetition, but it crosses over different areas of executive functions, but apathy or lack of motivation. So people tend to lose interest in things that they used to enjoy. I've had a number of people that I'm working with, I'm trying in rehabilitation psychotherapy, trying to develop new interests or getting them out of the house, getting people engaged. And that can be very difficult if apathy is present, and also just a tendency that can happen with personality after brain injury is what we call that blunting of emotion. So not being blunt, but more having a restricted range of affect as well. So people can seem very dry, have a hard time perceiving humor, understanding humor, because that's more of a metacognition process. And then also, it's really interesting. So if you've seen one person with a frontal lobe injury, you've seen one person with a frontal lobe injury. You're probably not going to ever see somebody like that again. I'll give a couple examples of this. So in people that it's just several cases that kind of come to mind with this. I've had people that have suffered brain injuries, gotten very agitated, irritable, and often getting into interpersonal conflicts up to violence. Now, I have had two really interesting cases where the two people suffered severe traumatic brain injuries, and per their wife, per husband, per family, they were described as being a very difficult person before the injury. And after the injury, for some reason, that meanness goes away. Now, oftentimes there will be some childlike or some regressive behavior as well, but a couple of times I've seen people that have said, this head injury really has improved my quality of life because I'm in a better mood. I'm not recommending head injuries, and that's a very, very small subset, but I bring it up because it's interesting and it can happen. More often, personality changes, involve more negativity, more hopelessness, those sorts of things as well. So just overall negativity in thinking. All right. So mood is controlled by multiple areas of the brain. We think of the temporal lobes a lot of the time, but certainly frontal lobes are implicated in mood. So brain injuries, either acquired or traumatic, really place people at significant increase for changes in, how their psychological functioning is. Sometimes we see mood swings, not typically getting up and so people will kind of describe being on a roller coaster, but they get downs, but not necessarily ups. So maybe the up is just a little bit lower than normal mood. Bigger issue is impulse, quick to anger. And then if impulse control is a problem, that can really lead to problems. So, being angry, if you can inhibit yourself, you're probably not going to get yourself in trouble. But if you're angry and you can't stop yourself, you're going to have some thoughts that may come across your mind. You may act on those without even realizing you're doing so. And then that leads to a lot of problems, potentially even, criminal issues. I've certainly seen that. Some people develop obsessive compulsive behaviors. Not quite sure what the actual mechanism for that is, but more importantly is the increased risk for depression. So after brain injury and stroke, the risk of depression goes up significantly. Part of that's likely an organic issue, so an issue with the brain, but also after brain injury and executive dysfunction or problems with the frontal lobes, people have loss of function or changes in their life. So there's often situational factors. I can't work, so stresses of not having the money and financial problems, those can all play into mood problems. Also, I've seen a number of people develop anxiety secondary to the brain injury that really is more physiological. And that can also switch from mood disorder into some thought disorder, such as hallucinations and things like that. But that tends to be very rare. So I'm not really going to go into that much. Another thing is that reduced range of mood. So oftentimes, in particularly in certain injuries, we see what's called blunted affect. So somebody doesn't show facial expressions when they're talking, they don't have vocal inflections. So it's really kind of monotone. And then also what typically goes with that is just feeling blah. So maybe not depressed, but something that we call anhedonic or anhedonia, which is a lack of emotion or just being there. There's also something that's called pseudobulbar affect. Now, this is, you may have seen this in pharmaceutical ads. There's now a medication that treats this, and it's on the nightly news all the time. But pseudobulbar affect is when you have an injury to the frontal lobe, and people can develop either laughing fits or crying fits. The critical part of this is it's not associated with feelings of happiness or sadness. I saw somebody recently this year that just started to cry in the session, and it was very clear. I'm not sad. This is what happens. Other people laughing at inappropriate times or what appears to be inappropriate times, and really can't control it. So people can attribute a lot into that, but the medication that we have now tends to be pretty effective with that. All right, now the other part is insight. So that's our understanding of us, the situation, kind of what the cause and effect is. And I often see insight problems with moderate to severe brain injuries. Again, acquired or traumatic, it doesn't really matter. So this might involve inability to understand the nature and extent of one's problems. So, I don't have any problems. You test them and their memory's at the first percentile or, different areas, but they just don't see it and they don't understand it. And it's not a psychological denial. It's just, it's not that connection is just not being made. And the issue with that is it can have marked impacts on an individual's functioning. I often see this in dementia, whereby people don't have insight and they're living alone, they're not safe, they don't have the memory to remember to take medications, they're cooking, leaving the stove on. So in those cases, and in severe traumatic brain injury, there's certain circumstances where that inability to understand one's deficits places somebody at enough of a risk where we have to think about a more restrictive living environment and more oversight, if you will. This also falls into the understanding of cause and effect relationships. So if you don't have insight into, if I do this, this is likely going to happen, you're basically doing single trial experiments where, who knows what's going to happen. So that ability to, take that second and think, okay, if I do this, this negative consequence may happen versus this positive. And again, in the extreme, this results in something that we call anosognosia, or people pronounce that differently. This is every case I've seen has involved frontal lobe injury where the person really doesn't believe that they've suffered a brain injury and that they're having a problem as a result of this. And I'm going to talk about I'd like to talk about a couple cases with this. One involved a construction worker that I saw who fell 4 stories, had a frontal head injury, not a lot of physical issues. And I started working with him in the post-acute rehabilitation timeline. So it's about 5 months after the injury. He was completely amnestic for the event. So he did not remember falling. He did not remember being in the hospital. And by the time new memory started to lay down, he was feeling fine. He didn't think there was any issues. So part of what we were needing to do was, before we discharged him, because this was an inpatient facility, was to try to get him to understand this and to understand these deficits, because they were going to cause big problems. So one time we videotaped the person doing a memory task, and they just bombed on it. And we showed them the video, and they said, "That's not me." So it's very difficult to deal with that situation where somebody is not just being defensive, they're just not understanding. More recently, I had a very difficult case whereby somebody, again, had been he was in a car. This person was in a car accident, singular frontal lobe injury. This person had previously had an extensive criminal record, had been in jail several times for, I think, approximately totally in totality of about 8 years. The person had this injury after being out of jail, but was, again, completely amnestic for right before the accident and all the way through his inpatient rehabilitation. So by the time I saw him, my family members came in with him, and he said, "There's nothing wrong with me. I don't need to be here. And I don't know, basically everybody that's complaining about me are the ones with the problem." He started to conflate, which means confuse, his time in rehabilitation with his time in jail. So this really caused even greater issues because his family was struggling. He was moving around, couldn't hold a job. But his belief that being in the hospital was actually him being in jail, and him not appreciating the fact that he suffered a brain injury, led us to that we really couldn't come up with any intervention strategies. One, because he didn't believe it, and two, because he had enough competency that we didn't want to file on him for inability to care for self, because he was with supports, he was able to do so. But one of the concerns is that we really weren't able to treat anything. He wouldn't take medication because there's nothing wrong. And his family, it was a very sad case because there was not much I could do other than to say, here's what's going on, and try to keep the best eye on it as you can. There are medications that can help with this, but my concern is that person will end up back in jail because of their premorbid history and their agitation level that was secondary to the brain injury, and a lack of understanding that it was tied to the brain injury. So it wasn't getting treated. So those are two cases that really kind of stood out to me as particularly challenging. And the latter one was particularly sad because this person was clearly had issues, and the family was doing their best, and it caused marked distress on them. So, and any feedback they provided, it would just result in an argument. So when you have anesthesia or a complete lack of insight, you're not going to be able to talk somebody into this. So when I met with him, we showed him pictures of the car accident. I showed him pictures of his MRI, which showed damage, showed him his medical records. He said, "Thank you for showing me that. That's interesting, but it didn't change a thing." So really not incorporating it because he has no memory of it. So this can cause huge problems in relationships, and then in working to adapt to develop solutions to problems. Because if you don't have insight, really, and you're not getting help from others, or not taking that input, it really is going to lead to some major issues, including potential risky behaviors. All right, so that's kind of going over the list I initially came up with. So damage to the frontal lobes and executive functioning can include the above issues, but also other multiple symptoms. So when we open this up for questions, please feel free. The frontal lobes do a lot, and executive function covers a lot of ground and overlaps in a lot of different areas. The specific constellations of problems really is often determined by the nature of the injury and the location of the injury. In addition, other factors that are involved are, people have certain resiliency, other people have more vulnerabilities. So really with brain injury, it's very hard to predict based on the mechanism of injury and even on imaging how somebody's going to be doing over time. Also executive functions clearly place people at significant risk for negative consequences. This includes social isolation because, again, if you're not having that social emotional reciprocity, you're not having meaningful relationships with people, people tend to fall off, particularly friends. So a lot of times when I see somebody who's had a head injury, maybe in their 20s, by the time they're in their 30s, it's usually family that's only in their lives. Friends will stick around in the healing time, but really don't want to spend too much time if people are saying inappropriate things or not tracking, and it just becomes very difficult. There's not a one size fits all that to address these issues. You really have to kind of break it down per what the issue is and the individual, and not having an expectation that if somebody has a frontal lobe injury, that they're going to have all of these issues. It's really potentially going to be some, maybe the majority, or just a few. So the nature of the head injury is very important, as far as whether it's diffuse on the frontal lobes or whether it's more focal. So let's see, yeah. So again, the interpersonal problems, financial problems, social problems, increased risk for incarceration, all of those things. So I want to talk a little bit, let me just jump back. I'm going to go to here. So I'm going to talk a little bit about specific problems related to specific areas of damage. So in general, with people that are right-handed, where language is dominant on the left hemisphere of the brain, what we often see is with left frontal damage is apathy, indifference, a loss of initiation, often loss of libido, reduced or no verbal output. Then right frontal brain injury, very different. So that's more likely you to see more aggressive behavior, even maybe more immature behavior, to lack of tact or restraint. Some people may have hypersexual behavior that can be very problematic, certainly, propositioning people in inappropriate places, saying things that shouldn't be said. Also lacking in social graces. So not really understanding, having lost the understanding of the social norms and that we tend to need to follow to get along in life. Also some motor agitation, just irritability agitation wise. So with left frontal injuries, you tend to see more slowing. With right, it may see more activation. People are doing more things, but you may also see deficits in perceiving facial expressions. And that's really important in conversation, because a lot of, there's the verbal part, but there's the nonverbal communication that's really important to be able to pick up on subtle cues, to be able to pick up on other people's reactions when they're not talking. And so if there's problems with that, it can really cause some significant issues. So I want to talk about orbital frontal damage. I want to jump ahead just to talk about what I'm talking about. So this is right in this area of the brain. So with the orbital frontal damage, what we tend to see is reduced inhibition. Again, very similar to what I've been talking about with right frontal damage. So inappropriate behavior. I bring up sexual acting out because that is something that often will bring somebody to my attention, and often raises concern within family members that somebody's going to do something that's going to get them arrested. And I've certainly seen that happen, and also, work to try to mitigate those issues. Let's see. And then deficits in perceiving of facial expression. So this would be more, and that would be more right orbital frontal. So the dorsolateral damage, let me show that where that is. So the dorsolateral is more on the top part of the frontal lobes. And oh wait, wrong way. Oh, don't look at that. I'm giving away the fun stuff. Okay, so here we tend to see more of that, again, depression or depressed personality, depressed functioning. So reduced libido, mood changes that aren't good. A lot of depression, a lot of flat affect, a tendency to perseverate or just repeat and get sort of fixated on something, not in a positive way where you're making progress in something, but just kind of going over it again and again, or not being able to let go of slights, not being able to let go, or not being able to process, and accept changes. So it can really be quite an issue. And then poor inhibitory control with increased impulsivity. So the ventral medial area, where's my slide, is right in the middle right here. And deficit, what we see here, and these are all based, most of this data comes out of stroke data, or a lesion, or where there's lesions, where there's damage to this particular part of the frontal lobe, and then we extrapolate from that. So with ventral media, we often see deficits in the social emotional behavior. That's that give and take in conversations. It's empathy, it's understanding, but we also see poor decision making. And this is going to lead to issues with following social conventions. So if you see a number of different areas here where there can be damage, where somebody can get in a lot of trouble. So one of my major concerns in working with somebody with a frontal lobe injury who's more activated is, how do we keep this person, safe from themselves and from other people in a way that's, productive? And for those people that have more of the depressed, not depressed as in depression, but more apathy, indifference, we really work on behavioral activation, use of certain medications, and I'll talk about that a little bit more. All right, so interventions. So cognitive rehabilitation. This will mostly be done by speech language pathologists. Metacognition, they work on problem solving, planning, organizational skills, also dealing with complex attention. So there's a number of different approaches to addressing executive dysfunction, depending on what it is. In addition, medications are used. So for those who have significant impulse control problems, medications such as Depakote or Lamictal, which are mood stabilizers, those can have a positive impact. I talked about the emotional part with the pseudobulbar affect. There's a certain medication for that, but also for we also use a lot of different things for depression and anxiety. Typically, maybe an SSRI like Prozac, Paxil, maybe one of the more serotonin and norepinephrine medications like Cymbalta, or even Wellbutrin, which gives a little bit of a dopaminergic burst and gives a little bit more energy to help somebody motivate. In addition, a lot of use of stimulants, particularly with apathy, fatigue, the attention problem. So these aren't people that necessarily have had attention deficit disorder, but those medications are, to be blunt, the best cognitive enhancers medications we have. As a side note, there's Prevagen, there's all these different over-the-counter medications, and the literature does not support them being effective. So if you're spending $65 a month on one of those, please just send it to me, or maybe just take that money and burn it, because it's not helping. Really, it's unfortunate. And it's unfortunate there's supplements so that they don't have to provide FDA. They don't have to go through an FDA regulation process, so they can make claims, and those claims do not have to be backed by science. That is a real problem. And I often have referrals saying somebody wants Prevagen, or I'm sorry, not to pick on Prevagen because there's a number of them. And it's, my first discussion is going to be, that's not something that I would recommend, but let's figure out what's going on. Let's figure out a better way of dealing with this. So anti-anxiety medications may be needed if there's a lot of agitation. And with the hypersexuality, that's been somewhat challenging to deal with. So on several cases where it was it was right on the cusp, the police had been involved. There was use of high dose serotonin reuptake inhibitors because those cause sexual side effects, and then some other medications that tended to have a dulling feature, because these individuals were going to do, or had done things that would have, could have gotten them arrested had they been put in jail, had people not been aware of what they were doing and why. So, but again, this is very, the more severe the frontal lobe injury is, the more challenging it is from a medication or rehabilitation perspective, but also from a family perspective as well, and friends, because you're seeing, just so much difficulty. Obviously, if you don't have insight into the deficits that you have, it raises a number of issues, particularly if you're having also memory problems or other attention issues. So this may involve people that are cooking and leaving things on the stove. They're driving in a car, getting lost, not really comprehending that they shouldn't be driving, and that they have deficits that get in the way of that. And while some gains could be made in working on these executive issues, usually if there's significant damage to the frontal lobe in moderate to severe traumatic brain injury or stroke or aneurysm, people can be left with lifelong deficits. For those people that are close to individuals who really are more of the acting out, that are more disinhibited and more impulsive, maybe more aggressive, we really need to provide a lot of caregiver support. This is very stressful, and I think one of the advances that we're making in rehabilitation is understanding the consequences of caring for individuals dealing with this, and it falls on family members. So as much support as we can provide, we try to. So I do want to point out I'm going to talk about two additional cases, and one is one that is just befuddles me, if you will. So this was this is somebody who served in law enforcement, and they were shot in the left. Sorry, wait, let's see if I get the pen going. Right here. Wait, no, it's not drawing, is it? Let's see. Oh wait, whoops. Sorry about this. See if I can use the laser pointer. Okay, so here, the bullet entered here. You see the pathway, and it ends here. And this over here, this is looking straight on the person's face. This is the bullet that's lodged in the back of the brain, so back of the occipital lobe. So the individual has, it's a left-sided injury. He has right-sided hemiparesis, so can't move his arm, leg is, we're working on mobility in that. This person is about 6 months post injury. And really the only major deficits that I see are in blunted affect, some speech issues, not being able to articulate thoughts as clearly, and then some shallowness in conversation. So not getting into deep things, more surface level. These are things that we've talked about and that we're working on and addressing in therapy to kind of modeling behavior. But when I saw this MRI and read the records, I was not expecting somebody that was going to be able to, be as functional as he is. So, the person wants to return to work as in law enforcement and may well be able to in a year, depending on whether the physical symptoms get better. Second case is one where actually the person had an aneurysm that burst in the back of the brain, and unfortunately it bled so much that they first put in they drilled a burr hole, put in a shunt to get out to release the blood and the excess cerebrospinal fluid, then had to do another one because it was the intracranial pressure was building, and then had to do what's called a craniotomy, where you take off a flap of the skull and allow the brain to swell out. Well, the reason I point this out is this area right here. So the damage was right here, the bleed was right here, but what happened was it pushed the brain forward into the skull, and the skull has some ridges on it. And right here, it's maybe a little bit hard to tell, but you'll see that there's basically some missing brain matter here. And this is what we call encephalomalacia. So there is, it's not that the brain matter isn't there. The consistency of the brain matter is more like a sponge, and the functioning is impaired. So this person has multiple issues related to this part of the brain injury, but for this part, the primary feature is apathy, and also the inability to initiate activities. So this person had owned a business, was married, currently lost the business, couldn't be able to maintain that just because couldn't plan, couldn't track, couldn't deal with customers well. So would get easily frustrated, had a lot of trust issues with family members for good reason. So ended up losing that business. And then the inability to understand, what his problems were. And he definitely has lack of insight, has made it very hard on his wife and on his family as far as trying to help out, because there'll be a problem that develops with their kids, and he'll come up with a solution that won't make much sense, and so they tend to ignore him, which is very dismissive. He wants to be involved in his kids, but on the other side, his decision making is very poor. So what we're working on is behavioral activation, trying to get him out doing things, trying to work on insight. He's on the max dose of a stimulant medication. So from that perspective, I think we've kind of maxed out. but also has refractory depression because this was more of a left-sided injury. There is some hopelessness and depression due to the losses that he's had, but it's also losses because he didn't have the ability to continue on with those life functions, to be in a relationship and to be present, to be able to handle his business on his own, or even really at this point to work fairly basic level jobs. He can do some things well, but if he doesn't feel that they're important, he won't do them. One example was, this was in a big box store. He was walking around the warehouse wearing earbuds during, while customers were around, and didn't understand why that was an issue. And we went over this in detail. Look, this is a safety concern, it's liability. Customers need, it doesn't look good. Customers need to talk to you, they need to ask you questions. Just didn't register. So that's challenging because that resulted in, his problems at work resulted in him now working only 4 hours a week. And, I think he's going to lose that job. And now we're bringing in vocational rehabilitation, where we're going to have to really think hard and long about what are areas of strengths and weaknesses and come up with a plan that fits him. And that's what's really important within rehabilitation, is not looking at things as, oh, this is a brain injury, we're going to do A, B, C, and D, but to get as much information as one can and to try to get a sense of, where are things breaking down and what are the steps that we can take with those breakdowns to try to help. Now, sometimes we can't, but other times we can move the ball a little bit. Other times we can move it a significant amount. So, the more information that I have and the more understanding of kind of all of the different areas of thinking, the better I can kind of help with treatment planning. And that's what I do as a neuropsychologist, is, assess those areas. So we have multiple tests of executive functions, from problem solving to decision making, complex attention, working memory. We have whole batteries of tests of the frontal lobe functioning because it is so significant, and damage to the frontal lobes can be so devastating. Not that other areas won't be as well, but few areas have this ability to affect thinking, behavior, understanding, personality, and mood. So it really does raise a lot of issues. And I have a lot of other stories or case examples that I could provide of, the really sad situations where that lack of insight or impulsivity resulted in a very negative outcome. So, all right, well, that's it for the slides. So what I was hoping to do is to open it up for questions, comments, discussion. Yeah, so I don't know. Let me see if maybe if I stop sharing. I see that there's some chat question or something in the chat. Yes. Okay. Yeah. I see the comment about, the lack of insight. It is it is incredibly challenging. And it, in some ways, is hard. It's harder on family members, treaters, and other people in those people's lives, because they're seeing the problems and they see what's going to potentially happen. And, steering that ship is very difficult unless somebody's in an inpatient or restricted environment. Advice for family members and caregivers. Absolutely. First of all, get support. Be in a support group. You may want to see somebody individual. This is going to be stressful. The more severe the executive dysfunction is, the more difficult, caring for somebody and making sure that everything's on, running well is critical. Also, with irritability, anger, which can be violent at times. I mean, we have definitely had patients that have tried to hit me because they didn't like what I was saying or what I was doing. Fortunately for me, that they were slowed down because they were in the post-acute phase. But I've also had patients that were violent that had fully recovered and were very strong individuals. So, this is really difficult. But for caregivers and family members, we need to. Support is absolutely critical. Understanding what's going on and being able to process this. And then also, kind of making sure that, or hopefully that your loved one or the person that you're working with is getting the appropriate treatment. The problem is we don't provide lifelong treatment. And again, this is very difficult to deal with. So, I don't want this to be a depressing talk, but in some respects, those people with major frontal head injuries, it is very sad. and very difficult because they're getting things taken away from them and they're not understanding why. Why can't I drive? Because of A, B, and C. I don't have those problems. No, you still can't drive. And that's tough. I mean, because again, we're not talking about a psychological denial process. We're talking about an inability to understand. And you can't talk somebody into that. You just can't. So any other questions or comments or?
Hi, can you hear me?
Yes, yeah.
Good to see you, Dr. Hall. This is Mike and Lynette Morgan in Iowa.
Yes,
And
hi.
good to see you. Is there any plasticity of the frontal lobe in terms of regenerating some of the parts that are damaged?
Yes, so let me start first with preventative stuff, okay? Just as a neuropsychologist, what I recommend for brain health is exercise, eating a good diet, and being involved in multiple mental activities. We used to talk about doing puzzles, crossword puzzles, and Sudoku. Recent research shows that socialization, even engagement in watching TV, that's interesting, reading, doing multiple different things, particularly those that draw on complex attention and those things, can provide what's called neuroprotection. Once you have frontal head, sorry, I just got totally, what was your question again? I'm sorry, I was going off on a different tangent, but.
Yeah, dealing with the ability of the.
The neuroplasticity of the frontal lobes. So with brain injury, and this is both acquired and traumatic, what we expect is improvement, natural improvement within a year to 2 years. And then that's augmented by speech pathology, physical therapy, occupational therapy, a lot of different things. So there is the ability for people to develop better ways of coping with this. One of the problems is if somebody lacks complete insight, they don't have that motivation to do things that are going to potentially help either clear up wiring, rewire. We don't quite know on a microscopic level what happens. But if somebody does have motivation, absolutely engaging in speech pathology where they're working on problem solving, they're playing, I'm just throwing these things out, chess or even, cross stitching. Those sorts of things, have a significant potential to increase neuroplasticity. Is it going to repair the damage? It depends on how much has happened. Once you reach a certain critical mass level, we're trying more just towards a little bit of benefit versus those people that we can have some moderate impact on as well. So there is neuroplasticity, and then, in addition with different treatment modalities, we can try to enhance that. At this point, we don't have any medications that, regenerate brain cells. There's no stem cells treatments, but who knows for the future. And I think Elon Musk is building a chip for people with brain injury. I don't know what that's going to involve, Neuralink. So brave new world ahead, but this is very challenging as far as, working to resolve these problems, but not a hopeless situation. And again, it's going to depend on where that issue is. So if somebody's, if it's more right and there's more apathy, that gets in the way. And then fatigue as well can go along with brain injury. So dealing with those things as well. So really it's getting people, engaged in things. So if it's a severe brain injury, I like people in a day program where they're engaged in multiple different activities, that they're involved in peer relationships, that they're using that part of the brain. The brain isn't a muscle, but the more we use use different areas, the better it goes. We do develop new neurons as time goes by. When we learn new things, we're laying down new pathways. So, but sometimes when that damage is too much, we just try to work around it the best we can.
And it also includes attention spans. Can you
Absolutely, yes. So attention is also in the frontal lobes to a degree. So people have problems staying focused, easily distracted. That plays into working memory as well. So absolutely, yeah. Yeah, but when we're talking about executive functions, that's not so much attention. I characterize it differently, even though it's housed in similar areas. So when you see problems with executive function, you often see attentional issues as well. People can look like they have ADHD, attention deficit hyperactivity disorder, or at the least. So that disorder is also implicated in with frontal lobe injury, attention deficit hyperactivity disorder, and stimulant medication. Particularly with those that are hyperactive, you'd think that giving them speed would just crank them out of the crank them up too much. It actually is a paradoxical effect where it can slow people down so that they're not flooded with these thoughts. So with frontal lobe injury and attentional issues, I see a lot of use of Adderall, Ritalin, Vyvanse, Provigil by physical medicine rehab doctors or physiatrists. So we aggressively go after that because the attentional component responds the best to any of the medications that we have. And attention is the route into memory, so we hopefully get a boost off of that. But we also have to worry about, is this going to increase irritability? Is it going to increase agitation? So it's a real balancing act. In addition, you don't want to do overly sedating medications. I talked about gabapentin and Lamictal. Those can be sedating, and it's a balancing act between treating problems that could happen due to the mood issue and personality issues versus slowing the person down more and just causing more collateral cognitive deficits. So it's really difficult. I mean, frontal lobe injuries are quite difficult. And to take this another step to dementia, there's a certain kind of dementia called frontal temporal dementia, which goes after the frontal and temporal lobes, mostly frontal. It's the earlier onset dementia. So if you're in your 50s and dementia occurs, that's most likely frontal temporal. And it is a bad course. People have all of the issues that I discussed, often apathy, people overeat, or else they'll be on the other end where they're acting out. And again, potentially getting in legal trouble. So
thank you very much, Dr. Hall.
Absolutely. Great questions. Yeah.